I'm Dr. Shivam Srivastava from Sankara Eye Hospital, Kanpur, and I will be presenting on the common causes of acquired nasolacrimal duct obstruction in different modalities of treatment. NLD obstruction is a blockage of the lacrimal outflow system that may be complete or incomplete and and has a various degrees of tearing, discharge, and infection. There can be exquisite pain, which can be because of acute lacrimal sac distension, which is because of the dacryolethiasis or the cystitis. There can be associated mucopurulent discharge when the obstruction is distal to the lacrimal sac or duct or at the duct. There can be clear tearing and there is punctal or canalicular obstruction. Coming to the epidemiology part, women are 2 times more prone as compared to men. In babies, there is congenital NLDO. Young adults are more commonly affected with canalicular obstruction and the herpes virus. And the facial trauma is another main common cause in young males. Middle-aged people are mainly affected with the dacryolates, common among the women and the smokers. Elderly have the primary acquired NLD obstruction. Coming to the etiology part, the involutional stenosis is the most common cause, is the idiopathic part. Then there is the dacryolethiasis, which is the stone formation or the cast formation within the sac. The trauma, particularly mid-face trauma, and the nasal orbitoethmoidal fractures. Then inflammatory diseases, be it sarcoidosis, granulomatosis, or polyangiitis, which is the vaginous granulomatosis, eosinophilic angiocentric fibrosis, and the lethal midline granulomas. And there are certain neoplasms of the sac, lymphomas, squamous cell carcinoma, papillomas, and the sinonasal tumors. And also the radiation therapies for malignancies are another causes. Some of the other causes include the displaced lacrimal plugs, dental impaction, and the nasal pathologies can be because of the cocaine inhalation, tumors, intranasal tumors, prior nasal or sinus surgery, iatrogenic damage from the functional endoscopic sinus surgery, or the chronic sinusitis or the rhinitis. There are certain drugs which are also implicated in causing of the acquired NLDO. Some of the chemotherapy medications, some of which include the Taxol derivatives, the docetaxel and the paclitaxel, 5-fluorouracil, radioactive iodine-131 therapy, and the phospholine iodine ophthalmic drops, and also the idoxuridine ophthalmic drops that are commonly used for the ocular herpes simplex infections and primarily result in the canalicular obstruction. There are certain important considerations. The timing of if there is constant tearing, it is indicative of the complete NLDO. If there is intermittent, it could be because of the dacryolet allergy, the impacted terminate, or when there is the incomplete or the partial NLDO obstruction. Tear quality, if the clear tears are present, it is punctular or canalicular obstruction. If there is copious debris with mattering, it is primarily because of the NLD obstruction. Blood-stained tears, if present, the tumor has to be ruled out. Lesion can be at any level, be it at the conjunctiva, the sac, or the gland. It can be idiopathic and may be associated with severe epistatic, bleeding diathesis, and corneal diseases. The clinical features are the excessive tearing and the discharge. Occasionally, skin background may be present. If the sac is distended, pain, discharge, and the patient might present with some history of prior cellulitis. Intermittent blurred vision may be present. If the lacrimal sac mass is present below the medial canthal tendon, it is compressible with the mucoid or the mucopurulent reflex, it is an indicative of dacryocystitis. But if the mass is non-compressible and painless, we have to consider that it can be neoplasm and further imaging has to be done. And if it is painful, it could be because of the lacrimal sac mucocele with facial cellulitis. Coming to the treatment part, as a general treatment for ruling out for managing the etiologies, optimizing the lid hygiene and the dry eye and allergic treatment, and for the reduction of the mucosal edema, antihistaminics and antibiotics are advised. And radiation therapy is done if NLD obstruction is secondary to lymphomas. And surgeries that are done with lacrimal placement. This is done if the obstruction is incomplete. And if there is complete canalicular obstruction, cysta definition is a technique that is done. Benign dacryloplasty, as discussed in the previous presentation, is common in pediatric NLD obstruction because it does not cause so much of pain and discomfort. Lacrimal duct stent because of the decreased success rate, not commonly done. Polyurethane stent success overseas is 18% only. The DCR, dacryoaspiring and stenting with or without mitomycin. The various approaches by which DCR can be done at the external intranasal. Endoscopic can be laser or face assisted. Endonasal with transarticular laser endoscopy. And or we can recanalize an endodiathermy bipolar fluid along with the adjuvant MMC. So when the malignancy is suspected, we have to biopsy. The lacrimal sac has to be biopsied and along with the intranasal lesion. And if the lacrimal sac tumor is present, then in that cases we would go for the DCT. The common complications of the external DCR include the infections, bleeding, CSF leak, and the scar formation. Thank you.
Thank you, Dr. Shivam. You can unshare the screen and answer the questions. Dr. Akshay?
Yeah, Dr. Shivam, well presented. I just had a couple of questions. You mentioned about a lacrimal sac, a firm lacrimal, when you can feel a non-compressible mass below the medial canthal tendon, that you should suspect a lacrimal sac tumor.
Yes.
So lacrimal sac tumors are actually extremely rare.
Yes.
There can be other causes, most commonly like an encysted mucocele, which basically is
Yes.
a mucocele that is not compressible, which is probably the most common cause of a palpable mass near the lacrimal sac. Also, if the patient has had multiple episodes of dacryocystitis, then there will be a small shriveled sac which may be palpable, and
Yes.
it will give you regurgitation. So, lacrimal sac tumors are actually very, very rare.
Yes.
The other thing is you mentioned in acquired nasolacrimal duct obstruction, probing is also a treatment modality. Yeah, in that slide, I think.
So, in cases of incomplete with
Right.
probing, if there is some
Dr. Shivam, you hold the mic near to your mouth and speak, probably.
Can't hear you at all, yeah.
We can't hear you.
I'm sorry. Actually, I thought
No, still you're not audible.
Switch off your video and try. Now you try, Shivam.
Am I audible?
Yeah.
No.
Yes.
You answer now.
Yeah.
So pardon me, couldn't just hear.
No, it is still not clear. You switch off your video and try.
Yeah. Now am I?
Yeah. Yeah.
Can-
Now you try answering.
Yeah. Can you pardon me with the question, please? So I could not hear actually.
Yeah, no, I was saying that you mentioned lacrimal sac probing and incubation is also a surgical option, treatment option for acquired nasolacrimal duct obstruction.
Incomplete and nasolacrimal duct obstruction. When there is partial obstruction.
So, how would you diagnose partial obstruction then?
So there are various tests that we can do. We can do lacrimal syringing. And Jones dye test we can do, Jones 1 and 2 that we can do for the diagnosing of there is a partial obstruction, and is it before the lacrimal sac or it is distal to the lacrimal sac, that we can do.
Right. So it's good to know the historical aspects of it, but Jones dye, I don't think I have ever seen a Jones dye test being done, and it's rarely ever done nowadays. So historically, that may be relevant. And also in adults, lacrimal probing, whether it is for acquired or for partial or complete Brock, is not something that is advised, because at the end you're having a bony canal, which is the nasolacrimal duct.
Yes.
So putting a metal probe and going through, there's a high chance that that is going to recanalize. So, and only in children where the NLD is very malleable and there is a membranous obstruction, do we do this? And just a note for future presentations. Whenever you put up figures or numbers, like I believe you put up one slide that said lacrimal intubation has a lower success rate of 18%. It's always good to put below the reference or the paper that you're citing. You don't want to quote numbers and figures without knowing where they've actually come from. So that's a good thing. And perhaps we could, since you're talking about etiology and surgical options, maybe a short video of what surgery options there are could also be there. So overall, it was a well-researched presentation. So well done.
Thanks.
Dr. Shivam, you can unshare the screen.
Yeah, Dr. Shivam, just a couple of things. It's actually an extensive topic. You're trying to cover the entire NLD in one short session of 4 minutes. When you're talking on such a big topic in such a small time, you should have an idea as to what you want your audience to take home, right? It's very difficult. So you don't have to tell all the reasons of NLD block. What is important is what has to be mentioned. Like Dr. Akshay mentioned that malignancies are very rare. You can just make a line. And the inflammatory conditions affecting the sac are extreme, even more rarer. So we don't see that much. So you have to understand what you want to impress upon your audience when you're talking on such a big topic. It's very difficult, actually, right? And yeah, as he mentioned, you have to give your references because there are a lot of studies that have been done, even as Dr. Akshay mentioned, adult probing and syringing for an adult NLD blocks. There was an article also from AIMS where they've done a large series of patients for adult NLDO with probing, and they showed good results, short-term results.
Yes.
So things like that are there. So if we can just give a reference for everything that you've done, so it gives an idea, okay, fine, you saw that. But the fallout has been that there's no long-term follow-up for patients who've actually had probing for adult NLDO. So probably they would have all failed. We don't know because our experience tells that. So that's what. So I'm not sure what their experience has been, but our experience with whatever patients we did for adult onset acquired NLDO, it was patent for 1 week and then it all failed. Well, that's a discussion for another day, nevertheless. But good effort in presenting such a big topic in such a short time, and well done.
Thank you.
Any other comments?
Nothing to comment, Madam.
Yeah. Dr. Shivam, you can unshare the screen. Can we all start our video just for a group photo session?
Immediately have to read.
All the students and the mentors here, please open your video for the group photo.
You pray without me?
Dr. Shivam, please stop sharing your screen.
Pray.
Dr. Padma Priya, Dr. Neetu, can you open your videos? Dr. Anuradha, can you all open your videos? Dr. Ria? Dr. Shushmita?
I'll take, ma'am.
So many have not opened the videos actually. Fine, you take.
Yeah, 1 second.
I was just having fun with my Lego. And this is a cool build, right? And I even made landscape. I made a landscape.
It's done, Radhika.
1
Yeah.
second.
Landscape.
Yes, ma'am, done.
Yes. So we have come to the fag end of the 3-weekend session now. On behalf of Sankara Academy of Vision, we thank all the judges who have taken the time, in spite of their busy schedule, to come and guide our students here. We congratulate all the students for their excellent presentations. We thank all our mentors who have guided the students in their presentations. We thank Ms. Radhika and Mr. Latif for their technical assistance. We hope the comments from the judges and the guidance from the mentors would have made the students further in their pathway towards a great teachers of future. Thank you, SAV, for giving me this opportunity to organize this session. Thank you all.
Dr. Vidya, thank you, Dr. Saptagirish. Wonderful idea. Wonderful idea to have all these students on the same platform, sort of like a competition, and getting external faculty to guide them. Like you had the best, like Dr. Akshay, Dr. Samresh, and these people are a few of the star presenters in the national level or even internationally. It's good to have it, and quite impressed by the standard of the students in Sankara. And see, it's always good to have an oculoplasty topic, because you can do impress people, and that's what happened today. And if there is an OPL, I always would love to have an oculoplasty person with me, because you have the videos and all. But it was not very easy for the initial presenters, because you can ask a huge lot of questions on IOLs and all. But they all did really well, because they're not really going into the practical aspects of what you do, the selection of the patient, what you do, selecting IOLs for the particular patient. That comes when you get into the practice and all. But all those kids did really well. Very good. Thank you, Dr. Saptagirish, for giving me this opportunity. Kaushik, everyone, Sankara family, thank you.
At the outset, I'd like to thank Srini, Akshay, Samaresh, and all the mentors and the students who did a fantastic job. And of course, Dr. Vidya, you sacrificed all your 3 Sundays for this. And of course, Srini also. But nevertheless, I congratulate all the PGs. They did a fantastic job, and they've taken an effort. And the best part is, as Srini mentioned, we've managed to get some of the stalwarts in present ophthalmology in the country. And the exposure of the students to talking to them and interacting with them is just fantastic to watch. And I'm very happy for the students, and I hope Samresh and Akshay have some good words for us. Thank you very much. Thank you, Vidya.
Thank you, sir.
So again, I'll start by thanking Shankara and Dr. Kaushik, Dr. Saptagirish, Dr. Vidya. It was, I think all the people presented very well. It was really nice, because everybody had done background research. So it was very tough competition, because it's competitive. It was really tough to mark the better one. I just have to add that a lot of you will be presenting, even on Teachers of Tomorrow on the national podium sooner or later. And so it's very important, because I was there at your place not too long ago. It's very important to keep things very relevant to the time and not dwell too much in the past, because past is gone and the present is what matters to the judges and the audience that's hearing. And like I said, keep it visual, because visual is appealing. But that apart, the presentations were really nice. I mean, not a dull moment during the entire 2 hours here today. Thanks.
Dr. Akshay, do you want to add something?
I just the quality of the presentations were really good. Some of them, like Samresh said, 10 years ago, 12 years ago, when we were in residency, we probably couldn't have come up with such presentations. So the quality of residents is better, is getting better every year. So yeah, this is a wonderful platform for them to learn to present. And yeah, because in soon they'll be presenting professionally at their different forums. So it's good to train them and help them, groom them before. Great. I had a good learning experience, because that was a lot of presentations were new for me, especially the cataract refractive ones. So it's good to have different specialists rate them, because a lot of that not only came, so I could also see it from the perspective of say another trainee trying to learn new things. So that's how I could appreciate the quality of a lot of these presenters.
Thank you, Dr. Akshay. Thank you all the judges for your comments. We'll be announcing the winners during our PG update session, which is scheduled about 2 weeks from now. Thank you all.
Thank you.
Thank you.
Thank you. Good night. Good night.
Thank you.
Good
Thank you.
night.
Bye-bye. Bye.
Bye.